Hello, and welcome to CodeSure, a place to learn about medical coding and billing. Today, we're going to review the medical billing revenue cycle. The revenue cycle is what keeps the doors open. Without revenue, there's no medical practice. So let's get started on this very important topic. Revenue cycle management and accounts receivable management are two sides of the same coin. Revenue cycle management refers to healthcare facilities. Accounts receivable management refers to a physician's practice. Both include payment posting, claim submission, and if a claim is denied, a claim follow-up. Both revenue cycle management and accounts receivable management are fundamental to the healthcare revenue cycle. So let's learn more. Revenue cycle management, as it's known in healthcare facilities, or accounts receivable management, as it's known in a physician's practice, are crucial for keeping the doors open. It's important to streamline this process in terms of revenue collection, but also for the importance of the patient's experience. Having a clear revenue cycle management process and the ability of either the healthcare facility or the physician to provide services to the patient. The medical billing revenue cycle can be a 3-step process, a 10-step process, a 15-step process. It just depends on how you decide to break it down. As we begin our detailed review, let's do a quick 11-step process overview. Some of this is really just common sense. You schedule the appointment. Of course you schedule the appointment. That's kind of silly. But during that time, you ask about insurance and you pre-register the patient. You call and confirm their insurance, or you establish how the financial responsibility will be adhered to. You will have your own specific designated code of guidelines to establish that responsibility. You insert the data, and again, that will depend on your healthcare organization, what type data you will capture prior to the physician encounter. The patient has the encounter with the physician, and then you check them out. The coders will review the encounter records and apply the appropriate code for the encounter. You will confirm billing compliance, and you will prepare and transmit the claim to those parties identified during the pre-registration period. You'll generate the patient statement, you will provide medical billing solutions, and you will follow up if payment's not made. Unfortunately, you may work for an organization that refers the patient to collections. We'll cover all of this in greater detail. Here's a flowchart of the medical billing revenue cycle. It's basically what we reviewed in the last slide, but it does show you where boondoggles can occur and what you do, back and forth. As you see in the electronic claims, they may be denied, or there may not be an electronic claim. That's when you use the CMS 1500, or when you correct and resubmit a claim. Is the claim valid? If it's not, then you back up and resubmit and review. There are in the revenue cycle process known steps when there may be problems. It's important to pay attention and make sure that in this process where you know there could potentially be problems, to confirm that your BIRG is accurate. We'll go over each of these steps in the coming slides, so let's move forward. A very important element of the patient revenue cycle process is appointment scheduling. This can include confirming insurance information, which will ultimately be the basis of any billing. A gracious and kind attitude and demeanor during the appointment schedule is crucial in retaining the patient. Working at the front desk in any healthcare organization is probably one of the most underappreciated jobs. But this is also where you obtain the consent for treatment and the patient's designations for release of information. Patient demographics such as financial and healthcare insurance are verified. Hopefully, the information about the healthcare insurance has been documented prior to the patient arriving at the healthcare facility. Pre-certification and pre-authorization screening for medical necessity is provided at this point as well. The data, which will be the basis for the medical billing, is captured through charge masters. Charge masters or encounter forms identify procedures or services provided. ChargeMaster is used not only for the direct encounter form, but it is also used for ancillary services as well, such as laboratory or x-ray. Diagnosis and procedure coding is the basis for all billing. The coder assigns the appropriate ICD-10-CM and the ICD-10-PCS or the CPT HCPCS Level 2 code. These codes represent the services provided, documented in the medical records. Inpatient services are DRGs or MS-DRGs. Outpatient services are APCs. There are many options in this course to study coding and billing. During the patient encounter with the healthcare provider, it's important that the healthcare provider document all services provided, which will be the basis for coding and for billing. Only those services provided and documented may be included in the medical coding and ultimately in medical billing. All patient information is documented in the medical records from the patient encounter or placed in the billing system and the CMS 1500 or the UB04 claims. These are the claims that are generated and submitted to third-party payers. A third-party payer would be an insurance carrier. This is what you don't want to see happen. Rejected. When submitted claims are incomplete or contain erroneous data, they are classified as rejected and they are denied. Avoiding claims rejections and claims denials represent the primary reason you're studying this topic. But let's take a close look at what happens with the claim rejection. If your claim fails to meet certain data requirements and there's missing data, such as the patient name or the policy number, it can be corrected and resubmitted. However, this will delay the reimbursement process anywhere from 30 to 90 days. A claim denial is effectively the same thing as a claim rejection. But in a claim denial, the information is present. There's just an error. For example, the policy name may not match the policy number. There may be coding errors. You may have coded information regarding an encounter that does not exist in the medical records. There may be a diagnosis that does not support the medical necessity of a procedure or the service performed. There may be duplicate claims. There may be a service provided for which the provider is not eligible for payment. A pre-authorization for the service provided may not have been obtained prior to the service, or the procedure provided may not be included in the patient's health care contract. An example of this would be cosmetic surgery. Typically, it is the job of the staff to confirm that the procedure is covered prior to providing the service. Claims rejections and claims denials are a part of the revenue billing process cycle, and they're also avoidable with experience and knowledge, and that's what we're working on today. Patient registration occurs at the front desk. I think people that work at the front desk do not get enough credit. They truly are one of the most important elements of the treatment process. This is when pre-admission clearance occurs. This includes a pre-certification, a pre-authorization, and a screening for medical necessity. During this time, appropriate consents for treatment and releases of information are obtained. Patients' demographics, which include their financial accountability and their healthcare insurance information, is collected. Their insurance coverage is validated, and a utilization management is performed to determine the medical necessity of the services which are to be provided at the encounter. Third-party payer reimbursement postings are made once the payment is received. This posting represents revenue to the healthcare provider. Rejected claims are resubmitted at this point with modified documentation to support the claim. This process includes electronic remittance or receiving reimbursement for third-party payers electronically. The process of resubmitting a claim is what everyone wants to avoid. Before you resubmit a claim, you may review the late charges, the lost charges, and corrections to previously processed CMS 1500s or UB04s. Resubmitting claims always results in delays of revenue. This can create a serious hardship for healthcare providers. What happens when you receive reimbursement but it's not what you expected? Variations in expected payments occur. When this happens, you appeal to collect the reimbursement that you anticipated. This process is initiated with a letter of appeal to the payer. Here is a quick overview of the claims adjudication and payment process. Payment clearinghouses transmit claims data to the payer. The payer then performs a validation process. There are three options. The payer approves the claim for payment. The payer denies the claims and requests additional information, or the payer rejects the claims. If the claim is approved for process, remittance advice is then sent. If the payer denies the claim and requires additional information, the payer generates remittance advice and sends that to the provider, but no payment is made. If the payer rejects the claim, the provider can resubmit the claim after correcting the errors or providing the information that was omitted. Additionally, the provider can appeal the claim if denied. Not all billing includes a payer that's an insurance carrier. Sometimes the patient themselves are responsible. These self-pay balances are billed to the patient. They can be deductibles, co-payments, or non-covered charges. These reimbursements are posted to the patient's account. Payments not received from a patient may result in collection letters. They can ultimately result in turning the patient over to an outside collection agency. Thank you for joining me in this brief overview of revenue cycle management. I hope you were able to see the important role the medical coder plays in the medical billing process. Every step is important, and every person has a job to do.